Hello everyone. Now we'll be discussing about nerve injuries. So these nerve injuries are very common when we do impactions, and especially when we do horizontal impactions, the nerves are bound to get injured if the proximity of the apices of the root and the inferior alveolar nerve are very close to each other. Apart from that, in traumatic accidents or orthognathic surgeries, nerve injuries can happen. So, in an entrance point of view, you should know Sedol's classification and Sunderland's classification. Then you should know about what do you mean by neuropraxia and how much time it takes to heal and what is neuropraxia. Then axanthomesis, then neurotomesis, and then you need to know how to do the nerve grafting. So these are the few areas where the questions are generated. So to begin with, so first and foremost, the anatomy of the nerve. So you all know that the nerve, there are three layers in the nerve. The outermost layer is called as epineurium, outermost layer. Then the layer next to that is called perineurium, and the innermost layer is called as endoneurium. So epineurium, perineurium, endoneurium. So endoneurium is the most inside. So where your axon will be there and your Schwann cells will be there inside endoneurium. So it's a multi-layered protection is there. So that is what you should be knowing this. So MCQ can be generated, which is the outermost layer, which is the innermost layer. They can give three options in sequence. They can change epineurium, endoneurium, perineurium, or perineurium, endoneurium, epineurium, like that. Arrange in correct order. You have to mark A, B, C, which is that option. So one MCQ is that one. Okay. So now coming to the nerve injuries, what we see. So now this diagram tells everything actually. So now you see this is a normal nerve where everything is going up, but there could be degeneration or there will be a cut at different levels. You see here this is completely degenerated, and from here the lower part is degenerated, or here the conduction blockage has happened or injury has happened. So at different levels the injury happens and different signs and symptoms develops in the patient. So this is what we are going to discuss. So coming to the first of it, that is the classification. You should know what is neuropraxia, what is axanthomesis, and what is neurotomesis in detail. This is very important. So many MCQs are generated from here. So neuropraxia, the first one. So here the conduction blockage which results from mild insult, just mild injury. You are doing an impaction, you just touch the nerve. That's it. Very mild. You didn't cut through and through. It's just an insult. There is no axonal degeneration. This is very important. Please make a note of it. In neuropraxia, there is no axonal degeneration. Then, what is the sensory deficit? How the patient will look like? What he will experience? He will experience mild paresthesia. So, little numbness in some areas he can feel. Then, the normal detection but poor discrimination and disturbed interpretation. He cannot pinpoint exactly which place, but he is telling, the patient will tell, I have a disturbed sensation over here. It is mild paresthesia, and this can be sorted out within hours to weeks. That will go up if you give neurobion or vitamin B12, the nerve regenerator. It will solve the problem. So simple medications will solve the problem, but it may take some hours to weeks for it to recover. So neuropraxia is no axonal degeneration. It is just mild insult to the nerve. That's it. Next one is axanthomesis. So the axon is getting hit and it is getting degenerated. So there is axonal degeneration. So this is a severe issue now. But the nerve trunk is intact. The nerve is there, but the axon degeneration has happened. So there is severe paresthesia. Patient full numbness. He cannot feel any sensation over there. And it takes several months, maybe 6 months, 8 months, or even a year for them to recover. that is called as axanthomesis, where is axonal degeneration take place. Now the third one is neurotomesis. Neurotomesis means it is the severest form, whereas there is cut and cut, it is just cut. The nerve is almost chopped. So nerve trunk is cut through and through. It is cut through and through, and there is anesthesia and dysesthesia, and it is a permanent damage. So nothing can be done. So it's a permanent damage has happened. So one MCQ can be, in which of the condition there is axonal degeneration. So that neuropraxia, axanthomesis, neurotomesis, that is one MCQ. Like that, they will tell the pathology and they will tell what is the term for it, or they will tell the sensory defect and they will ask you what is the it is called as, whether it is called as neuropraxia, axanthomesis or neurotomesis. For example, permanent damage, so we know this permanent recovery is not possible in which of the conditions: axanthomesis, neuropraxia or neurotomesis. So like this you should be, questions will be generated. This one slide which is there on your screen, you can solve almost like 10 to 12 MCQs. So same thing, this is the example of neuropraxia. There is this axanthomesis and this is neurotomesis. You can see here full cut is there. This part, whole thing is cut into two pieces. So this is piece number 1, this is piece number 2. So it is separated. That is neurotomesis. Okay. Next is, what do you mean by Tinel sign? So it is the start of nerve regeneration. So whenever the nerve gets injured or there is an insult, so nerve wants to regenerate. So the start of nerve regeneration, tingling sensation will be there. The tingling sensation is called as Tinel sign. Very commonly asked MCQ this is. So we have discussed about Sedon's classification, that is neuropraxia, axanthomesis, neurotomesis. Three terms or three categories comes there. Three types of nerve injuries come there. Now there is one more classification called Sunderland's classification. Very important. So the Sunderland's classification are having degrees like first degree, second degree, third, fourth, fifth and sixth degrees. So the first degree, second degree, third degree are same of Sedon classification. So nothing changed. So first degree is neuropraxia, second degree is axanthomesis, and the third degree is neurotomesis. So same thing what we studied in Sedon's 1, 2, 3 is Sunderland's 1, 2, 3. So this whole thing we know it. So the first one, the first degree is also called as neuropraxia. So axonal conduction blockage as a result of ischemia or mechanical demyelination can occur. Mild paresthesia, few days to week it will recover. Same thing, no change here. Second degree, axonal degeneration but with the nerve truck intact, severe paresthesia, few months it will take. Very simple it is. Third degree, that is your axanthomesis, cut and cut, severe paresthesia, and it is persistent for a very long period of time. So 1 to 3 degrees is of Sunderland's classification is same of Sedon's classification. Now coming to 4, 5 and 6. So the fourth one, apart from the axons and the endoneurium, the perineurium also gets damaged here. So here endoneurium and perineurium both gets damaged. Anesthesia or dysesthesia is there and it is a persistent. For a very long time it will be there. Fifth degree is transection of the entire nerve. Entire nerve is cut and there is anesthesia and permanent damage it is. And the sixth degree is mixed combination of any of the upper 5, 1, 2, 3, 4, 5. So sensory defect may be variable and even recovery possible, not possible, no one can say anything. Mostly it will be permanent loss of sensation only. So this is Sunderland's classification. So you should know what is Sedon's and what is Sunderland's classification. Now let us do some MCQs. Right. So mechanicoceptive testing includes. Now for example, a patient comes and he tells I have paresthesia. So first is you should try to know which area the paresthesia is. So you have to take 2 points, point A and point B. So you can mark, like you can take a compass, you can put it from here to here or here to here. The patient has to tell. So how will you test that? So first and foremost, you will check like this with the normal thing. He's telling no sensation. Okay. Then you will take 2 points and you will try to ask whether you have paresthesia or anesthesia or not. That is one method. Then is brush stroke, like your painting brush, the camel brush is there. With the bristles, you will see whether the patient can or is having any sensation or not. So, mechanicoceptive testing includes 2 point discrimination, yes, static light touch, yes, and brush stroke, that is also yes. And even vibrational senses also, all those things, any vibrations are done, the patient knows or not, he needs to identify and tell. So, the answer most probably it is all D, all of them are included. Next question, your static light touch evaluates A, beta, alpha, delta, all of the above. So it is A, beta fibers, the first one, A, beta, static, and it even tells about the pressure perception also. Not only touch, but even the pressure sensation also it will be telling, A, beta. Grafts most commonly used for trigeminal nerve repair. Now, if any trauma happened and completely gone, the mandibular nerve or trigeminal nerve, any part is gone, it is cut through and through, and you want to reconstruct it. So, you have to take a nerve from some parts of the body and then transplant it here. So, the sural nerve, this is in the leg, in the lower part of the leg, you have got sural nerve. Great auricular nerve, that is behind your ear. So both of them are very, very important. Both of them should be the answer. Sural nerve and great auricular nerve, they meet the most of the requirements for a transplant or when you want to do a grafts. So you will put this nerve and combine and mix it with, fuse it with the mandibular nerve or maxillary nerve, whichever trigeminal nerve. It's just like a patchwork you are doing. So you got sural and great auricular nerve. Both of them meet the requirement. Which material can be used for trigeminal nerve grafting? So grafting, which material? Alloplastic tubules, skeletal muscles, vein grafts, all of them are used for the grafting. So you can do grafting of the trigeminal nerve. So alloplastic, skeletal muscles you can make from that also, and vein grafts also. So in the topic of nerve injuries, you should know basically Sedon's and Sunderland's classification, neuropraxia, xanthemesis, neurotimesis, and little bit of Wallerian degenerations. You can know the distal part gets degenerated whenever there is an injury. Proximal part escapes and distal part gets affected. And Tinel sign, and then which damage is permanent, which is within hours or weeks. That is the question. Nerve grafting, and from where you take the graft, and so these are the questions which are more important in the topic of nerve injuries. So that's all in this topic. Thank you.